Welcome to this Essential Explainer. If you're an MRCOG candidate, you're going to want to pay close attention because today we're dissecting some highly testable updates from the RCOG Green-top Guideline 27A. We're focusing specifically on Placenta Praevia and the Placenta Accreta spectrum. Now, these are high-stakes, life-threatening obstetric conditions, so mastering the evidence-based management mapped out in this guideline isn't just about passing an exam, right? It's literally about saving lives on the delivery suite. Let's get right into it. We're going to follow an escalating clinical pathway today. We'll start with definitions and risk factors, move on to diagnosing placenta previa, cover previa antenatal care and delivery, and then we'll scale up to the placenta accreta spectrum before finishing with accreta surgical management. All right, part 1, definitions and risk factors, specifically looking at the 2018 terminology update. Now, what's really interesting here is how the 2018 guidelines completely threw out the terminology you might remember from older textbooks. This is absolute exam gold, so lock this in. Based on the AIUM classification, we now define placenta previa strictly as when the placenta lies directly over the internal os. That's it. For pregnancies past 16 weeks, we only use the term low-lying placenta when the placental edge is less than 20 millimeters from the internal os. If it's 20 millimeters or more away, it's just considered normal. So those old terms like partial or marginal previa, you literally need to delete them from your vocabulary. If you see marginal or partial in a clinical vignette on your exam, you've got to mentally convert that to these exact millimeter measurements. That strict 20 millimeter threshold on a transvaginal scan is exactly what drives your correct management choices. Moving on to risk factors, just look at this dose-response pattern. We all know a previous cesarean delivery increases the risk of previa in a subsequent pregnancy, but look at how aggressively it scales. Having one prior section increases the relative risk by about 4.5 times. But if a patient has had 4 or more prior C-sections, that relative risk skyrockets to nearly 45 times higher. No joke. Also, don't forget that assisted reproductive technology and maternal smoking are independent, highly testable risk factors for previa as well. Okay, moving to section 2, diagnosing placenta previa. Let's look at the ultrasound pathway. You really want to memorize the sequence for your exams. Your initial screening happens at the routine 20-week fetal anomaly scan. Now, because the lower uterine segment develops and stretches, about 90% of low-lying placentas simply resolve on their own. So if it's low-lying at 20 weeks, you bring the patient back at 32 weeks for a confirmatory transvaginal scan. And finally, for asymptomatic women who still have a previa or low-lying placenta at 32 weeks, you do one more scan at 36 weeks. That final scan is what definitively informs your mode of delivery. The absolute crucial point here is that transvaginal scanning, or TVS, is undeniably superior to transabdominal scanning. And yes, it is completely safe. Actually, TVS will reclassify up to 60% of placentas that were thought to be low-lying on abdominal scans. Now pay close attention to this specific ultrasound marker, cervical length. If the cervical length is less than 31 millimeters before 34 weeks, that is your massive hemorrhage warning sign. Those women have a 16 times higher risk of emergency cesarean due to massive bleeding. Right, on to section 3, previa, antenatal care and delivery, where our main goal is minimizing hemorrhage. Timing is literally everything in obstetrics. The evidence shows us very clearly that we want to target a single course of antenatal corticosteroids strictly between 34+0 and 35+6 weeks of gestation. As for delivery timing, well, if the woman is completely asymptomatic and uncomplicated, we're trying to balance fetal maturity against the risk of an unexpected, dangerous bleed. So the sweet spot for a scheduled delivery is right in that window between 36+0 and 37+0 weeks. When it actually comes to the delivery itself, we have to be clear, this is not a procedure for a junior trainee. It absolutely must be managed by an appropriately experienced operator, ideally with a consultant obstetrician and anesthetist physically present. Something that comes up on exams all the time is the choice of anesthesia. Regional anesthesia is favored over general because it carries a lower risk of hemorrhage. But, and this is the big but, you must consent the patient for a possible conversion to general anesthesia, just in case things go south. And obviously, you need blood products and rapid infusion devices on standby. Okay, let's turn the dial up a bit for section 4, the placenta accreta spectrum. We are escalating to the high stakes now. First things first, you've got to leave that 19th century term morbidly adherent placenta in the past. The modern standardized terminology is the placenta accreta spectrum, or PAS. This correctly acts as an umbrella for everything from superficial adherence, which we call creta, to deep myometrial invasion, increta, all the way to percreta, where the villus tissue actually perforates right through the uterine wall and can invade surrounding organs like the bladder. I really want this number to stick with you. 577. If a woman has both a previous cesarean section and a current placenta previa, her incidence of PAS absolutely skyrockets to 577 per 10,000 women. That combination is a massive, flashing red flag for your antenatal clinic. If you see an anterior, low-lying placenta over a previous C-section scar, your index of suspicion for PAS needs to be incredibly high. Antenatal diagnosis is essential for reducing maternal morbidity here. So how do we spot it? Well, ultrasound in expert hands is highly accurate as your primary screening tool. You're looking out for those classic moth-eaten placental lacunae and abnormal vasculature. But you should pull in MRI to complement the scan when you specifically need to map out the depth of myometrial invasion or see if there's lateral parametrial extension, especially with posterior placentas. Interestingly enough, the guidelines point out that the overall diagnostic value of ultrasound and MRI are actually quite similar when they're performed by experts. Which brings us to our final section, Part 5, Accreta Surgical Management, the Multidisciplinary Emergency. Notice the timing shift here compared to a standard previvia. To balance fetal maturity against the terrifying risk of massive, unscheduled bleeding, planned delivery for PAS is pulled back slightly. It should happen between 35 plus 0 and 36 plus 6 weeks. Waiting any longer than that dramatically increases the chances of an emergency delivery, and that is exactly where mortality spikes. There are 6 elements in the PAS care bundle, and they are basically non-negotiable standards of good care. You need your consultant obstetrician and anesthetist present. You need immediate access to massive transfusion protocols, robust multidisciplinary planning, highly specific consent covering things like hysterectomy and cell salvage, and a guaranteed level 2 critical care bed. Trying to deliver a PAS patient without this infrastructure drastically increases the risk of severe morbidity. Now let's look at the actual surgical steps inside the operating theater. Expert consensus emphatically recommends against attempting to separate an invasive placenta. If you try to pull it off, it leads to catastrophic bleeding. The safest approach by far is to deliver the fetus by actively avoiding the placenta, which sometimes means doing a high vertical uterine incision, then leaving the placenta completely in situ and proceeding directly to a cesarean section hysterectomy. Okay, watch out for this classic exam trap. Some older, outdated practices suggested giving methotrexate if the placenta was left in place for expectant management. The 2018 guideline is crystal clear on this. Methotrexate is of unproven benefit, it carries massive adverse effects like myelosuppression and nephrotoxicity, and it is explicitly not recommended. That's a grade C recommendation against its use. But what happens if you're in the middle of a routine C-section and unexpectedly find a percreta? Well, if you open the abdomen and see it before opening the uterus, the safest move is actually to just close the abdomen back up, delay the procedure, and immediately assemble your multidisciplinary team or transfer the patient to a specialist unit. On the other hand, if you only discover it after the baby is born because the placenta just won't detach, do not tear at it. Leave it right where it is and proceed immediately to an emergency hysterectomy. As we wrap up this explainer, we really have to look to the future. While uterus-preserving techniques like the triple P procedure and interventional radiology are showing a lot of promise, they still lack large randomized controlled trials. So we're left asking ourselves, how will we balance the incredibly human desire to preserve fertility against the severe, life-threatening risks of hemorrhage and sepsis while we wait for definitive data? It's a profound clinical challenge, but mastering the foundations we cover today is your very first step in safely navigating it. Keep studying, best of luck to all the MRCOG candidates, and we'll catch you in the next explainer.